My name's Liz Dorey. I'm the end-of-life care facilitator. Looking around the room, I know most people, but for those people who don't know me, my background is that for many, many years I've worked in health and social care. I've worked in the community services. I then was a CNS in palliative care for about 14 years before going to the Institute. And then I've now started this job where I'm working on projects to improve end-of-life care. So I'm working with the specialist palliative care team.
Hello, I'm Jenny Lene, and I've been a specialist palliative nurse for about 10 months, and before that I was acute surgery for about 12 years.
So what we're talking about today, as Vicky's explained, is that we're looking at how we've used the Safer Everyday project to start about introducing the individualised care plan for the last days of life. So why look at individualised care plan? Because caring for people at the end of life, as everyone knows, is really important. It's a kind of thing that we can only do once. One of the reports that came around as a result of problems with the Liverpool Care Pathway, which we'll talk about later, was one chance to get it right, and that's what we've got. When we were auditing the care that we give at the end of life, looking at the notes that we've got, there were some good examples of compassionate care that we'd given, but we didn't record everything, so we couldn't show that we were doing all the things that have come out in the NICE guideline. So that's why we embarked on doing the individualised care plan project. What do you need to do end-of-life care? Dr. Kerry Thomas, who started off the Gold Standards Framework, which is a system of monitoring people in the community at the end of their lives, said that you need your head. We need to know what to do, so we need the knowledge of what to do. We need hands, we need to know how to do it. We need the organisation and to get everything in place with the so that we can use the heart. So that's the compassionate care, the kind of human dimension of why we're doing it. So Vicky came round to tell me about the Safer Everyday project. And as we know, the Safer Everyday project is looking to create an organisation that's at ease with itself, I suppose, that looks at things like creating an environment where everyone feels comfortable and there's opportunities to ask questions and raise concerns, being held to act in a safe and respectful manner with training and support to do this, because that's a very important part, is all the training and support. It's looking at developing a shared understanding about anticipation of needs and problems and agreed methods to manage these for not only the staff but also for patients and families. And it's about getting genuine agreement on matters of importance to the team members and the families. So that's the kind of culture. Then when we look at the organisation itself, we need to make sure that we're learning from what we do. So when something goes well, that we learn from that and learn to do more of it. And when it doesn't go so well, we learn and don't repeat it. Improving processes and patient outcomes. So we need to look at standard improvement tools and management over time. Wrong way. And we need to make sure that everybody's getting equitable care. We're not getting some patients getting a lot more than others. And that we're openly sharing data and information concerning safe and respectful care with staff, but with patient and families as well. And on top of all this is that facilitating leadership so that there's mentorship, improvement, respect and psychological safety. When Vicky came to talk about this, I thought that's the kind of organisation I'd like to work in, where everybody's respectful and we've got a culture that feels safe. So these projects are trying to kind of get us close to that really, and we'll talk about how we go about it as we set off. But first of all, Jen will just explain a little bit about the Liverpool Care Pathway.
So the Liverpool Care Pathway is what used to be used to put people on who were dying as a guideline. It was to try and get the excellence of hospice care within organisations into a general setting that everyone could use, but it wasn't particularly individualised to the person, and it was aimed more at health professionals, not families involved or people having more of a say in their own care. It didn't really have any way of being reversible. Most people who were put on it, which was a big fear, was that they weren't necessarily removed or reviewed from it, because sometimes we don't always get it right when we think somebody is dying. There can be a reversible cause for their symptoms and they may improve for a while. So it was quite generic that people maybe were placed onto that and didn't have their care regularly assessed. So it's been removed to try and make it more individualised. So I'm just going to talk a little bit about the 5 priorities of care, which is what we've tried to base the new care plan for end-of-life care on. Firstly, recognising when someone's dying, which sounds quite simple, but it's not always straightforward. There can often be quite a few reversible causes of someone presenting as if they're dying, which could include infection, dehydration, possible chemotherapy causes, having a high calcium. So we want it to be recognised that they are beginning to die, and that everybody is aware of that, and that recorded deterioration is in their notes, and that they are an expected death. And then communication is really important to provide the seamless care. So we want the families and those who are identified as important to the loved one to be involved in their care and all the decisions, but also the communication between health professionals to always improve and evolve, really, so that we're all talking to each other, involved in that person's care. So by involving them, we can actually start to hopefully use this end-of-life care plan to talk to them about what their family may have expressed, or what they may have expressed as important to them in the last days of their life, or what they'd want. And by supporting them, we're going to be respectfully trying to live out as many of their wishes as possible and give them the control over their own care, really. By planning and doing, we obviously mean that everything that we've now discussed with them and put onto the care plan, we want to now put into practice for them. So we want their care to be individual in the case of what they might have expressed about food and hydration, and what they would prefer, what they might have expressed about symptom control and what they would or wouldn't want, their spiritual needs, and all of these things are usually evolved out of a discussion with who's important to them, and I think they'd hate that, or I know they've always particularly wanted that at the end of their life. So it's just trying to tailor it to be really patient-centred.
We set off on this journey in 2017. Val and Linda were on the part of the original working party that consisted of people from all over the community in Guernsey. So we had the specialist palliative care team, we had a palliative care consultant, there was one of the physicians, representatives from nurses throughout HSC, and also from the Nursing Home Forum and the hospice. GP leads, end-of-life care leads from each surgery, and a pharmacist, and of course a chaplain, which is spiritual care is an important part of this journey, really. So we set off with a working party looking at what we were going to do. We did some draft guidelines, and then we developed a couple of documents to start off with. One was the important thing was getting sorted out with the symptom algorithms. So these are the medications that we need to give to control symptoms at the end of life, to help promote safe, effective care for people who are dying in the last days of life. Looking round at the documents and with our links with Southampton, we based it on the individualised care plan for the last days of life that's been used in Southampton area. They'd tried it out and got through some of the problems, so we decided to give that document a try. Then we looked at staff engagement. It was decided that it was going to be it's a document that's only going to be used in the last days of life. It's a paper document that's going to be kept with the patient, and it's going to be for everybody to use. It's important that everybody takes part and fills in the document, because at certain times of your life, like I was a midwife as well, so when you're born and when you die, meticulous care is really important. So that's why it was felt important that it was a multi-professional document.
So when the journey started, we decided to trial it with the champions of end-of-life care, really, more in the areas where death is experienced more in those care areas. So that started with Carey Ward, Breon Ward and all the community teams, and just beginning to educate the GPs about its use in the community as well. And when we all got together as working parties, some of the reasons for wanting to take part in the project came out of the system, that it would hopefully just help less experienced members of staff to realise what happens in the last days of life and to support families a bit better and more holistically. Help teams to anticipate care needs and review that so that everything is in place if someone is recognised, with symptom control as well as the personal individualised care. Would ensure consistency of care across the board in all walks, and would be a source of information and MDT communication, and hopefully just help everybody to be more organised and guide everybody so that there's a standard for everybody to follow to ensure nothing gets missed.
So the next thing that happened was that we set up what's known as a driver diagram template, which is part of the Safer Everyday project. We found this quite helpful as a working party that was looking at this, because it helps you think about what are you actually aiming to do. So the aim was to enable patients and those important to them to receive individualised care in the last days of life. How we're going to tell that we're doing this is notoriously difficult with end-of-life care, because we can't ask the patient themselves, how was it? And it's a very emotional time for everyone. So some of the measures that we looked at that we could use would be feedback from bereavement visits that most healthcare and social care professionals do after the death. Looking at the Voices survey. This is a survey that's done in the UK where the carers of people that have died within 3 months ago are sent a questionnaire, and they're asked to fill this in and send it back. This would be run by the Public Health Department, so it's kind of separate from HSC itself, and it would be gaining their opinions of how well cared for their loved ones were in the last days of life. We also thought we could evaluate the care plan. There's the Royal College of Physicians audit tool that we could look at, and the NICE guidelines. And one of the things that we put in deliberately was a little section that asked carers and those important to them what were their main concerns, because in that way we could maybe look and see if we'd actually address their concerns. So then we needed to think, what do we need to make sure that we're actually going to achieve this? So after much thought and coming up with help from Vicky, we came up with the things that we'd need to get in place. So we need to individualise the care for the dying person and those important to them. So we need to create a care plan that is based on these principles of best care, the best evidence we've got, the 5 priorities of care. But we also need to make sure that their relatives and those important to them understand what it's for, because that was one of the failings of the Liverpool Care Pathway. People just used to say they're on the pathway and not explain further of what was happening. We need to make sure that we've got an educated staff, so we need to make people have the knowledge and skills outlined in the end-of-life care documents to actually carry out the care. We need to make sure that they not only have the knowledge, but they've got the skills to be able to individualise that care for that particular person and their family. Documentation, this is obviously an important thing, that a document, as we said before, that everybody's going to use, so all members of the multidisciplinary team. And also what we're trying to aim to do, which is a challenge, is to make sure that we write things down as succinctly as we can, as clearly as we can, and in such a short way that we actually show that we've given the care, but we're not spending hours writing, that we're actually got time to actually care for people. Equipment is an important thing, especially for the relatives. In certain areas, like in the hospital, there's been work trying to develop a relatives room so people have somewhere they can go, but also we need to think about having facilities for them, so having recliner chairs and things, and we'll talk a bit about that further on. And MDT involvement is a really important thing, trying to involve all members of the multidisciplinary team in the project so that they understand what we're trying to do and what we're aiming for. So, to that end, the next thing that we did to get the project started was consult all the committees that we needed to go through to get the permission and to make sure that what we were doing was right and kind of fitted in with the kind of various guidelines and things that are in the organisation. So the Drugs and Therapeutic Committee, obviously, because they had to make sure that the medication we were giving was safe. We then went to the Senior Nurses Forum, the Clinical Reference Group. We attended the physicians' meetings and the GPs' meetings to try and talk about it. Also, couldn't fit them all on, but we went to see people like the physios and the OTs, just to try and get everybody's ideas about the project and make a start of it. The important bit about the Safer Everyday project that is actually really good is that before you used to go, right, we've got this document, we've had a word with everyone, everyone says, oh, that seems okay, let's give it a go. And then you'd go, right, well, we'll trial it for 6 months, and then everyone would go, well, it was rubbish. This way, we do the act, plan, do, study. So you set off with your objectives and you work out what's going to happen and plan out who's going to carry the care. You do it, you see what happened, and then you make modifications before you start the next cycle. We're now on version 4 of the document, so we have gone round quite quickly. Some things were obvious. I suppose one of the traps you could fall into is try to make the changes too quickly, because a lot of it is people just getting used to a very different document to use, really. So we consulted with, when we got the document up and running and we got the other things in place, we went to ward meetings, talked with GPs at the Gold Standards Framework. As I mentioned earlier on, Gold Standard Framework is a way of organising the care for people in the last days of life in the community. So most of the GP surgeries have a meeting once a month where they look at people that it's considered they might die within the next year to make sure that we've got all the care plan for them. There's still a little bit of work to do on that. We don't capture all those people, but the ones that we do know about, it does make a big difference. CareWatch, that's a service user group. We went along to them and talked through about what the aims of the project were, and they gave some feedback on the documentation. We're going to look at trying to make the documentation less clinical looking. So certainly the front page we're going to see about probably adding on kind of the pictures that we use in all the rest of the leaflets, just to make it less clinical. People felt that that would be helpful. And we've also then got feedback from everyone who's used it. So trying to capture feedback from the staff that have actually used it as to how it went, what we could do to improve it. As you can see, we made a little plan. I've got these for each of the drivers, each of the things that we're wanting to change to help embed the individualised care plan. So this one's about the documentation. So it's about that we need to have the documentation available to all members of health and social care, and to ensure that we can fill it in succinctly. So we've got the working party going, we've got the service users, and we've started with the documentation. While it's being trialled, one of the first audits I've done was I've just worked with the hospice, looking at how our documentation compares to the usual care that they give, that they record. So we've just made some changes to make sure that that's reflected. And the first bit is the very first time it was used. It was trying to work out kind of things that we'd not thought about really in community, was that you have to have a patient label on each page. So it was just about kind of working out that and coming to work out what we needed to do. Sticking with the documentation, this is talking about version 3, but we're just about to publish version 4 today. I'm sure many of you round here have probably not seen the documentation, but what it starts off with is an explanation for the patient themselves, if they're able to, well enough to read it, or the relatives, or those important to them, about what it is about, and what just briefly goes through the things that are likely to happen when somebody's dying. This has worked out quite well. We've had very good feedback from relatives, have found it very helpful. It's also backed up by a book called What to Expect, a booklet that we've got that goes into things in a bit more detail, that people find useful in community because it explains what the relatives could do to help, because the philosophy of this is working in partnership with the family. We've also got on the next page, that isn't available here, but it's got a blank page for relatives to write down questions. So especially in community, that's helpful because people think of a question, then the nurse isn't along for a little bit. The next section is about assessment. This is a section that is for both all members of the healthcare team and social care team to do the assessment on, because everybody knows different bits of it really. We've changed it round for the 4th version just now, so that all the bits that the doctors are likely to be contributing to are all at the beginning of the assessment document, whereas other bits further on, where other members of the team might have more knowledge of kind of further back. So it's got things like further back in the assessment document, it's got things like what equipment we might need in community, and it's also got about religious and spiritual care, which everybody would know about. Probably healthcare assistants might have more idea of the spiritual care than anyone else because they know them very well. So this bit, as you can see, is looking to review what we need to change, what we're going to step down now people have entered the last few days of life. So it's about things like medication. Are we going to, review the medication? Probably when we recognise that somebody's dying, they're not going to be able to take oral medication. So we need to change it to other routes if it's needed. We need to make decisions about hydration. That was one of the great criticisms about the Liverpool care pathway, was that people were not allowed to eat or drink even if they could, which was all a bit silly. It's all a bit silly, but it's about thinking about, is it appropriate to carry on with things like blood glucose monitoring? Would we need to do observations? And if so, why? Because there's no point in really bothering people if we're not going to act on things. And looking at things like the oxygen and things like that. Subcutaneous fluids, would that be appropriate at this time? So after the assessment document, we're kind of coming to the end of it. One of the things that's important is that we also have a section in it that asks, is this person still dying? Because it's an uncertain time. We don't always get it right, as Jenny said earlier, and that we need to review all the time. Maybe we've got it wrong, and maybe the individualised care plan isn't appropriate anymore. Why I've got this bit up is that bit about the main concerns of patients and those important to them. That's been a really interesting section actually, because most relatives have come up with, all that I'm interested in is making sure my relative's comfortable and that everything's done to care for them. Whereas people themselves have come up with different things. One gentleman said that he didn't really want a dry mouth, so he didn't want something to dry up his secretions because he'd rather have rattly breathing than a dry mouth. So that's quite an interesting section. The nursing care plan. Trying to write the nursing care down succinctly is the biggest challenge area, really, because there's so much that we need to get in. And what it has brought out, which is very interesting, is if we're looking at having best evidence care, the variations that have been going on in different areas, the real things that we're going to do further work on and produce posters to try and send out, make sure we're doing evidence-based care, is about things like mouth care. Lots of people have very great variations on mouth care as to what's the best thing to do. The other thing that's come up is about turning, changing position to protect pressure areas. At the end of the life, this maybe isn't the major priority, and that it's not looked upon as good practice to turn people completely from side to side, but to do a 30-degree tilt. So you tilt them from side to side using pillows. What's proving to be coming out is the great variation on this. Some people are very afraid that if they don't turn people, that they'll get pressure sores and there'll be a safeguarding incident. Other people have different views about that. So that's a further bit of work that we're going to be doing on. We'll be looking at this issue and looking about individualising care of pressure areas at the end of life. The other area that actually is showing that people are very uncertain of is spiritual care. People understand what a person's religion is, but spiritual care in that what really makes that person happy, what is them, people find more difficult. I was sitting with a family yesterday and we were talking about this, and suddenly the daughter went, "Oh, he loves Monteverni and the rugged cross." So they decided they were going to play that a bit in the background when there was nobody in the room. So it's about looking at these things really and individualising them. One thing that it's helped us to do as well is bring a degree of transparency. We know that hydration at the end of life is a tricky area because it's a great concern of relatives. They're worried that their relatives are dying because of lack of fluid. We can explain that everything's winding down and that's not the case. But as regards giving things like subcutaneous fluids, there's no good evidence one way or the other. So as part of the Safer Everyday project and thinking about transparency, there's some people from the Working Party coming with me tomorrow to the Ethics Committee to discuss about putting in a flow chart that will help guide staff and including it in the individualised care plan, and also asking them to consider kind of more difficult areas we get, where sometimes in the community setting the person can't swallow safely, they can't understand enough, they haven't got competence to say whether they want fluids. Sometimes we can't give subcutaneous fluids because there's a contraindication, they've got heart failure or something, but the relatives are still insisting that they want to give them fluids. We're going to ask the Ethics Committee just to kind of discuss the ethics around that kind of situation and give some guidance on things like that. So it's helping with the transparency. A more successful part of it isn't causing as many queries and things, is this symptom observation chart. This was used from Brighton. They've been using it. So you've got, it looks very like a news chart. So in hospital, everyone thinks, oh yeah, that's great. It looks a bit like news. This is good. And actually in community staff are reporting it's helpful as well. So at a glance, you can see how well the symptoms are controlled. So naught means that the person has never had that symptom. So he's never had breathlessness or pain. Number one means whatever you're doing to control the symptom at the moment is working. So if you've got a syringe driver going, or the way you're positioning them, that's actually doing the trick. So that's the green. The yellow means that we've had to do some intervention. So that's usually a registered nurse has had to have some intervention to make sure that the symptoms are controlled. Whereas the top one, the red, means that the nurses and everybody working with the patient, the health and social care people that are caring for them, haven't been able to control the symptoms. So then it's time to get hold of medical colleagues or specialist palliative care team. That is proving to be quite, people are finding that useful. And then the back of the notes is for people to write in just significant things that have happened. So it could be conversations with relatives, and for colleagues such as medical personnel to write in, and for those kind of things to happen. That's actually proving difficult. The problems that we've got to kind of talk through is that people are duplicating what they've actually recorded in the earlier part of the document. So that's a kind of problem. We need to say, no, you don't need to do that, because that's just, you're wasting time. You could be using that doing mouth care or sitting with the person or doing something more useful. The other problem is trying to get all members of the multidisciplinary team to actually feel that that's part of their document as well. That, you know, people say, oh no, I'll still write in the medical notes. One of the things that happened was I was caring for a gentleman on one of the wards medical units, and the physician had given excellent end-of-life care. He was an elderly gentleman who thought he wanted to survive till his next birthday, and he had some treatment and it wasn't working, so then he changed his mind. So the doctor listened to him and his family, and the kind of pace of the care was changed. And this gentleman said that he'd had a rattly breathing for a long time because he had kind of a heart condition, and that he'd actually rather have rattly breathing. He knew it would probably upset his family, but it didn't upset him, but he didn't want a dry mouth. So the doctor was saying, okay, we won't give any hyoscine then. Problem was, it wasn't written down in the notes. So I was with the other nurses, and the patient couldn't tell us at this point, or the family weren't there. So we'd given some hyoscine, and then we realised afterwards that actually he didn't want that. If that had been written down, we could have really individualised the care, and that person would have had the kind of care that he wanted, really, because dry mouth is not as nice, even with good mouth care, because it's very drying, some of those medications. So that's a kind of example of why it's important that everybody takes part with the records. The next driver really is about educating people. There are some courses being run at the Institute. There's some workshops over the next couple of months for unregistered nurses and registered nurses that look at how we use the individualised care plan, and about exploring about the 5 priorities of care. So everybody's welcome to them. There are also other ways that people can get education through the Nursing Times that we can get in HSC online. There's some of the modules that are suitable to help with end-of-life care. And as part of the project, we've developed competencies which outlines the knowledge and skill that people need to be able to undertake this role. So this one that's for recognising that somebody's dying is a competency that's been developed for people who frequently care for people who are dying. So there's 3 different levels really. The first level is for specialist palliative care, that people have had extra training. This level 2 is for everyone who regularly cares for people that are dying. It's kind of generic kind of outcomes, but you then work with your manager and base it on your role and the knowledge that you would need. And then there's another lot of competencies for people who it isn't their main kind of care. People will say like learning disability service. So that's mainly about them knowing how they can support the nurses that are caring for the resident, and then when they should get extra help if needed. We're just looking at bringing these competencies out. We're kind of talking about using them in community at the moment.
The next driver is just looking at the care plan really, and trying to get as much service user involvement as possible, and working mostly off the comments from the relatives that they put within the start of that document, or that they're feeding back to us with bereavement support, to try and get an idea of how involved they're feeling in the process, or whether there's anything we can do to improve that. And then the driver looking at equipment, we're just hoping really to improve the equipment in and out of the hospital for relatives and for patients. We're looking at getting more recliner chairs available for relatives in hospital that just want to be in the room and spending the night next to their relative. We're looking for getting comfort boxes for relatives, including things like toiletries, so if it was quite last minute and they're not going to plan to go home, they have more to look after them, and things like vouchers for canteen or support with meals. And there's a new project that we've just got a working party together on, looking at the use of adjustable beds in the community setting. We hire out a lot of equipment in the community, usually for 3 months free in a palliative situation, but we're just trying to get better at honing whose responsibility it is to identify the need for the equipment, and who should be sort of actively putting that in place. And we want to make that more individualised, that we've started to get feedback that the term hospital bed sometimes puts a lot of people off and creates quite a lot of fear. So we've tried to sort of modify that in our approach to say adjustable bed, or describe the bed, or give leaflets so that they know more about the equipment that's going to come into their home, because it is sitting in their front room normally, and it's a real invasion for them. And it also indicates usually that they're declining in care as well. We now have spoken to the equipment people about possibly being able to get double beds together, because there's often a fear that you won't be able to sleep together when you're in a community if you're a married couple who, or not married, anyone who wants to spend the night next to their person. If you've had your loved one move downstairs and you didn't know that it was an option, that actually you could just have a bed next to them and you could hold their hand, and that option hasn't been given to you, then that would be a reason why the person might actually decline having the equipment put in the first place, which would make their care a lot more individualised and easy for them to manage. So it's just trying to provide them with as much information as possible now, really.
So MDT involvement, it's about attending meetings, discussing this, so Senior Nurse Forum ward meetings, but also carrying on going to the Gold Standards Framework meeting with GPs, trying to get feedback from other members of the multidisciplinary team, such as doctors and occupational therapists, physios. One of the things, the word is getting out, because we've had some wards approach us now saying, can we be part of this? So we're looking at rolling it out with this 4th version to Brock and Lamarchant wards. I wrote this during the snow, so calling this bit trips. I thought we'd see the end of trips, but they say it's going to get snowy again on Sunday, don't they? So what are the things that actually are kind of difficult to navigate, and maybe things that we need to think about? I've not put everything, I'll talk about a few extra things. But one of the main things that we found is that looking at kind of greater transparency and looking at the Safer Every Day, looking about culture and teamwork and communication, trying to work out which committees in HSC we should take things through to actually get the permissions to do the right thing was quite difficult. I found that quite difficult. And actually having somewhere where there's the terms of reference of the committees, and actually a bit about the procedure and the process of how you go through them would be helpful. Lack of staff, that's a big problem in certain areas, and one of the areas that wanted to be part of it, they've been struggling because they really just don't have time to kind of discuss things. We're having to look at different ways of trying to work with them to kind of introduce it safely. And one of the champions is going to leave as well, so it's about trying to adapt to that really. Recognising when somebody in the last days of life, this has tripped a lot of us up actually, from everywhere we've tried it really, because the other area that I was very remiss in not including is the hospice. They've been part of trying out the individualised care plan as well, and they've found, along with on the medical unit and everywhere, that we've put people on the individualised care plan and taken them off again because we thought they were at the end of life and they weren't. So that's good, because I think it shows that we're using it properly. One of the things that does seem to happen as well is that note-keeping culture seems to be really strong. People feel that they need to write reams and reams about the care that they've given. That's the nurses, whereas they're doubling up on what they've written already. So it's about trying to unpick that, why people feel that they need to do that. There's also then other people that we work with from other organisations, sort of like MSG, primary care. It's kind of, they don't feel kind of somehow part of the documentation. I somehow feel that they go, well, it's that's an HSC thing, we'll write in the medical notes. And maybe this is something to reflect on. Do we as an organisation, as HSC, how we work with people from outside the organisation, should we be having their logos on this document as well, because they've been part of the work. Certainly the hospice have been very much part of the work in developing it. So it's about looking at things like that and bringing that up with the various parts of the organisation that need to kind of think about it really. There's also other things that maybe could I have done better. One is a working party. Maybe we should have come out with some exemplars a bit sooner. I'm about to come out with one now and some questions and answers. So it's kind of, we could maybe have helped a bit with that really. But those are the kind of the main things that seem to kind of be occurring at the moment. But it is an ongoing project. We're on version 4 now, and we've added all these extra things to it about looking at hydration, looking at mouth care, looking at pressure area care, adjustable beds in the community. We've also got a working party that's looking at the use of subcutaneous fluids, not only in the last few days of life, but earlier on in a patient's journey. So it's just a kind of ongoing work in progress really. And I think that using the Safer Everyday project as a kind of a basis of doing it has been helpful, because I think it's helped us look at things in more detail and give us a structure on how to assess what we're doing and then keep on planning and doing and going round the circle so that we continually improve the care.